If you've been taking a blood pressure pill every single morning for the past year, amlodipine, Losartan, or Lisinopril, how confident are you that you truly understand what that pill is doing inside your body right now? Not what the label says, not the one sentence your pharmacist printed on the bag. I mean, actually understand it. The way it works, the way it can quietly turn on you under the right conditions, and the warning signs that separate a minor inconvenience from a situation that requires urgent medical attention. Most people I talk to, educated people, careful people, people who read the news and manage their own finances, pause when I ask that question. And that pause tells me everything. Because here's the thing, these aren't weak medications. These aren't vitamins. Amlodipine, Losartan, and Lisinopril are powerful drugs that change how your heart, blood vessels, and kidneys function every single day. And yet millions of seniors take them on autopilot with very little understanding of what to watch for, what to avoid, or when something that feels ordinary is actually a signal your body is desperately trying to send. Today, I'm going to change that. My name is Dr. Mandel, and this channel exists for one reason, to give you the kind of clear, practical, honest health information that too often gets left out of a 10-minute doctor's appointment. By the time this video ends, so going to understand these three medications in a way that makes you safer, more confident, and far less likely to be caught off guard. Supplement. And I want to start with something that happened to a gentleman named Walter, because his story sets up everything we need to talk about. Before we begin, take a second and tell me your name and where you're tuning in from. I go through the comments and I genuinely want to know who I'm speaking to and supporting here. Walter's story. Walter was 74 years old, a sharp, methodical former engineer. He took his medications exactly as prescribed, never missed. His daughter had set up a pill organizer labeled Monday through Sunday, and Walter treated it like a project schedule. When his doctor added amlodipine to his regimen, Walter figured it's one more blood pressure pill, same category, different name, no big deal. That assumption almost cost him a productive year of his life. 3 months later, Walter's feet had changed so much that he couldn't fit into any of his regular shoes. His legs felt heavy by 4:00 in the afternoon. He started limiting how much he walked, because moving around made it worse. He told his son he thought his circulation was failing. He was scared. He started Googling heart failure. The real answer was something much simpler and much more manageable. But Walter didn't know it, because nobody had ever explained to him that amlodipine, Losartan, and Lisinopril are not the same kind of drug. They all lower blood pressure. That's where the similarity ends. Amlodipine is a calcium channel blocker. It works by relaxing the walls of your blood vessels, specifically the smooth muscle inside arteries, so blood flows with less resistance. Lisinopril is an ACE inhibitor. It blocks a specific enzyme in your body that tightens blood vessels, so by blocking it, pressure comes down. Losartan is an AR, an angiotensin receptor blocker. It works at a similar step in that same system, but through a slightly different door, which matters more than most people realize. 3 different mechanisms, 3 different side effect profiles, 3 different things to watch for. When you understand that, you stop interpreting your body's signals with a one-size-fits-all lens. So Walter's swelling wasn't heart failure. It was amlodipine doing exactly what amlodipine does in a significant percentage of people who take it, relaxing arteries more effectively than veins, causing fluid to pool in the lower legs. Once that was identified and addressed, Walter was back in his walking shoes within weeks. The name on your bottle is not just a label, it's a category. And the category tells you the pattern. The swelling explained. Let's go deeper. Let's talk about that swelling more specifically, because it is one of the most widely misunderstood side effects in all of blood pressure medicine, and it affects a surprising number of people taking amlodipine. Here's what actually happens, explained simply. When amlodipine relaxes the small arteries in your legs, blood flows in more freely. But the veins, which are responsible for carrying blood back up to the heart, don't relax in the same way. So you get an imbalance, more blood coming in than going out. Pressure builds up in those tiny vessels near your ankles and feet, and that pressure eventually pushes fluid out of the vessels and into the surrounding tissue. The result: puffy ankles, socks that leave deep marks, shoes that stop fitting, legs that feel heavy and full by late afternoon. This is not fluid retention from eating too much salt. This is not your kidneys failing. This is not heart failure starting. In most cases, it is a predictable physiological response to how amlodipine works. Now, here's the part that becomes genuinely dangerous. Not the swelling itself, but how people respond to it. Some people see the swelling and decide on their own to stop the medication without telling anyone. And their blood pressure climbs back up quietly while they feel like they made a sensible decision. So, others keep taking the medication but start avoiding water because they believe they're retaining it. That's the wrong direction entirely. And dehydration on a calcium channel blocker carries its own risks. Some people, like Walter, simply endure it in silence for months, reducing their activity level, assuming the worst, and losing quality of life unnecessarily. The right move, the move I want you to remember, is this: leg swelling on amlodipine is a conversation your doctor needs to know about. Not because the drug is necessarily wrong for you, but because there may be adjustments, alternatives, or strategies that make it far more manageable. Elevating the legs, timing of doses, or in some cases, reconsidering which medication fits your body best. Those are all options, but none of them happen if you suffer in silence. If you or someone you know is taking amlodipine, drop a comment below. Have you ever noticed that heavy, swollen feeling in your legs by the end of the day? You might be surprised how many people are quietly going through the exact same thing. It's a cough nobody connects to lisinopril. Now let's talk about lisinopril and the most notorious side effect in the ACE inhibitor family, the cough. Not a wet cough, it's not a productive cough. A dry, scratchy, relentless tickle in the back of your throat that tends to be worse at night and doesn't respond to cough drops, lozenges, antihistamines, or anything else in your medicine cabinet. Here's what makes this one so tricky. It often doesn't start immediately. Some people develop it within the first week. Some take 3 or 4 months before the cough appears. And by that point, the connection to lisinopril never even crosses their mind. They've been on the medication for months without issue, so they blame dust, allergies, a lingering irritation after a cold, or acid reflux. I want you to meet Evelyn. Evelyn was 71, an avid gardener, and she assumed her cough was from spending time outdoors during pollen season. It was late spring when it started, which made the timing seem completely logical. She used antihistamines. She bought an air purifier. She mentioned it to her primary doctor, who ordered a chest x-ray that came back clear. 6 months later, the cough was still there. Her sleep was disrupted almost every night. She was tired, irritable, and starting to believe something serious was being missed. When she came to see me, one of the first questions I asked was, "Supplement, when did you start lisinopril relative to when the cough appeared?" She went quiet, pulled out her phone, and started doing the math. She had started lisinopril 11 months before our visit. Supplement. The cough had appeared about 4 months into treatment. She had never made the connection. Supplements. Once we identified the likely cause and worked with her primary doctor to switch to Losartan, which targets a similar mechanism but doesn't cause this type of cough, the tickle in her throat was gone within 2 weeks. 11 months of disrupted sleep gone in 2 weeks. Once someone connected the dots, now, and this is critically important, I need to draw a very clear line here. There is a symptom in the ACE inhibitor category that is not a nuisance. It is a medical emergency. If you are on lisinopril and you develop swelling of your lips, tongue, face, or throat, especially if swallowing or breathing becomes difficult, you do not wait. Do not call the office tomorrow. You do not take a Benadryl and see what happens. You call emergency services immediately. This is a condition called angioedema. It is rare, but it is real, and it can close your airway faster than you expect. A dry cough is a nuisance. Throat swelling is an emergency. The gap between those two things is important. Please burn it into your memory. Supplement, and if nobody has ever broken down your blood pressure medication this clearly before, hit that subscribe button. Because what's coming next in this video could be just as important for your safety or someone you love. The salt substitute trap now. Let's move to Losartan, and a danger that I find particularly striking because it doesn't come from doing something wrong. It comes from people doing what they believe is the right thing. Losartan, like lisinopril, works on the renin-angiotensin system, the body's blood pressure regulation pathway. One of the effects of this class of medication is that it can raise potassium levels in the blood. For most people, this stays within a safe range when monitored appropriately. But add certain common lifestyle choices on top of it, and the picture changes. Here's where it gets counterintuitive. Potassium doesn't just come from bananas or supplements. It's hiding in products that are actively marketed as the healthier choice, salt substitutes. Shoot, many popular low-sodium salt alternatives, the ones sold right next to regular table salt and often branded as heart-healthy, replace sodium with potassium chloride. So a senior who's been told to cut back on salt buys a potassium-based substitute, uses it liberally on every meal, supplement, and is now loading potassium into their system while taking a medication that already raises potassium levels. The combination can push potassium high enough to affect the electrical system of the heart. And here's what makes it dangerous. High potassium doesn't always scream at you. It sometimes announces itself quietly as unusual muscle weakness, persistent fatigue, a cramping sensation in the legs, tingling in the hands, or a fluttering, irregular heartbeat. Sometimes there are almost no symptoms at all, right up until there are serious ones. I want you to think about someone in your life right now, maybe yourself, who has switched to a salt substitute in the last year or two. If that person takes Losartan or Lisinopril, this is a conversation that needs to happen with a doctor. Not because the medication is dangerous in isolation, not because potassium-rich foods are evil, but because the combination, without awareness and monitoring, can create a slow-building problem that never needed to happen. Electrolyte powders, some meal replacement shakes, and certain over-the-counter sports recovery drinks also carry meaningful potassium loads. They're not prescription products. Nobody thinks to mention them, and that's exactly why they matter. When you get sick, the sick day plan there is one scenario that I don't think gets nearly enough airtime in conversations about blood pressure medications, and it directly affects seniors more than any other group. What happens to these drugs when you get sick? Not a serious illness, not hospitalization, just a bad stomach bug, a few days of vomiting, diarrhea that won't quit, loss of appetite for a couple of days, or simply a hot week in summer with heavy sweating and not enough fluid intake. When you're dehydrated for any reason, same dose of Losartan or Lisinopril that was perfectly calibrated for a well-hydrated body can act dramatically differently. Your blood pressure can fall too low. Your kidneys, which are already working harder due to the fluid loss, become more vulnerable. Dizziness, weakness, faintness, or acute kidney strain can develop faster than most people expect. Supplement, the medication didn't change. Your body's internal environment changed, and the drug is now operating in conditions it wasn't designed for. This is one of the most important practical things I can tell you today. Illness changes the rules. And if you don't have a plan for what to do when illness hits, whether to hold a dose, when to call the doctor, what symptoms should trigger a visit, you are leaving a significant gap in your safety. Supplement. That plan is something you should have from your prescribing doctor before you ever need it. If you don't have it, ask at your next appointment. What should I do with my blood pressure medication if I get a stomach virus or can't keep food and fluids down? It's one of the most important questions you can ask. It's one of the least commonly asked. Here's a quick question for you. Has your doctor ever given you a sick day plan for your blood pressure medication? Drop a yes or no in the comments because I have a feeling most of you are going to answer the same way. The painkiller in everyone's medicine cabinet. Here's a scenario I want you to visualize for a moment. You have a bad week. Your arthritis flares up. Your knees are aching. Your back is stiff. You head to the drugstore and pick up ibuprofen, something you've used for years, perfectly ordinary, something from the shelf that anyone can buy. Now you're taking Lisinopril or Losartan. Maybe you're also on a diuretic, a water pill for extra fluid management. This combination, when used regularly, can meaningfully reduce blood flow to your kidneys. And in the context of even mild dehydration, the risk of kidney injury rises substantially. This is not a hypothetical, rare scenario. It is one of the most common, most preventable situations I see. And the reason it slips through is simple. Patients don't think of ibuprofen, naproxen, or similar over-the-counter anti-inflammatory medications as real medications in the same category as prescriptions. They're just something from the drugstore, something for the pain, but your kidneys do not distinguish between prescription and over-the-counter products. They respond to chemistry. If you routinely use anti-inflammatory pain medications for arthritis, joint pain, or back pain, and you take any of these 3 blood pressure drugs, please have that conversation with your doctor. There are often safer alternatives. Acetaminophen, topical treatments, physical therapy approaches, or other options that don't carry the same kidney risk. You don't have to simply endure the pain. And you don't have to silently accept the risk. There's usually a better path. You just need someone to help you find it. The dizziness most people dismiss. I want to spend a moment on something that sounds small and isn't. Dizziness. It's that brief wobbly moment when you stand up from the couch or get out of bed in the morning. The world tilts for a second. You grab the door frame, then it passes. And you go about your day thinking, it's got up too fast. For many seniors on blood pressure medications, this is a regular experience, and it's almost universally underreported because it seems too minor to mention. Here's what I need you to hear. In older adults, a few seconds of dizziness is enough to cause a fall, and a fall is enough to cause a fracture. And a fracture, particularly a hip fracture, can derail an older adult's health trajectory in ways that take years to recover from, if recovery happens at all. This isn't alarmism. This is physics and biology working together in a way that demands respect. The dizziness happens because your blood pressure medications are doing their job, lowering blood pressure. And when you stand up quickly, your cardiovascular system hasn't had a moment to compensate. Blood pressure briefly drops. Blood flow to the brain momentarily decreases. Feel it as a lightheaded, tilting sensation. The fix is often simple. Rise slowly. Sit on the edge of the bed for a moment before standing. Hold on to something stable when getting up. Give your body a few extra seconds to catch up with the change in position. But beyond the practical adjustment, dizziness that happens regularly, dizziness that doesn't improve after the first few weeks on a medication or an episode of near fainting, those are signals that deserve a real conversation. The dose may need adjustment. A combination of medications may need review. Something in your hydration habits may need to change. Silence on this issue is not a small risk. Reading your numbers without panicking. Let me address something that creates enormous unnecessary anxiety and occasionally dangerous, impulsive decisions for people managing blood pressure at home. Blood pressure is not a fixed number. It moves constantly throughout every hour of every day in response to dozens of variables. How well you slept, whether you had caffeine, if you're in pain, whether you're anxious about the reading itself, whether you just walked in from outside, supplement, whether you spoke loudly right before sitting down. A single high reading on a random Tuesday morning after poor sleep does not mean your medication is failing. Single low reading after you've been dehydrated on a hot day does not mean your medication is too strong. What matters is the pattern over time, measured consistently, the same arm, same time of day, after 5 minutes of quiet rest without rushing or talking. When people monitor inconsistently and react emotionally to individual readings, the decisions that follow are almost never good ones. Extra doses taken out of fear, skipped doses because one reading looked good, frantic calls to the doctor about a number that, in context, is completely unremarkable. Monitor with a method. Track over time. Bring the log to your appointment. Let patterns, not panic, guide the conversation. That simple shift in approach reduces anxiety, improves decisions, and gives your doctor far more useful information than a single alarming screenshot from your home monitor. And if you've made it this far and you're getting value from this, type the number 9 in the comments. It's a simple way to let me know you're here and following along. See, these medications work through a steady, consistent presence in your system, not spikes and gaps, not extra doses when you're worried, and not skip doses when you feel fine. Amlodipine, Losartan, and Lisinopril are not rescue medications. They're not designed to be taken reactively, like a pain reliever after a headache appears.